Следующее слово. Значит, вообще я хочу сказать, что нам всем сидящим в этом зале очень крупно повезло, поскольку вот следующий доклад будет делать человек очень известный в мире. Это доктор Имад Наджм, который возглавляет эпилептологический центр в Кливленде. А мы знаем про эпилептологический центр в Кливленде, что вообще он в мировой практике эпилепсии является одним из, наверное, ведущих учреждений, может быть, даже первым. И самое главное, что там дело не стоит на месте, а постоянно движется вперед, и остальные только успевают угнаться за этим всем. Вот доктор Наджим является директором этого эпилептологического центра, и доклад его будет посвящен ошибкам, каким-то ловушкам в хирургии височной эпилепсии. Доктор Наджим, are you ready?
Thank you very much. Sorry, I don't speak Russian, so I'm going to speak very slowly. And if after 1 or 2 slides, some of you don't understand, I'll ask somebody to translate. I would prefer not, because it gets the flow much nicer if I speak slowly and you understand. Okay? So it's easy for me now to talk about temporal lobe epilepsy surgery after the elegant presentation that we just all saw, and beautiful illustration about state-of-the-art techniques in surgical resection in patients with temporal lobe epilepsy. As Dr. David just mentioned, epilepsy surgery, in particular temporal lobe epilepsy surgery, is one of the most commonly done or performed epilepsy surgery in the world. And at least during the early stages of epilepsy surgery, this is if we look between the early 1980s and mid-1990s, more than 2/3 of the epilepsy surgeries done involved the temporal lobe resection. I can say that at least at our center in Cleveland, nowadays temporal lobe resections are not the majority of the cases. Probably maybe around 1/3 of the resections involve the temporal lobe, in particular mesial temporal lobe, and we are seeing less and less hippocampal sclerosis. We are seeing more and more complicated lesions, MRI negative cases, corticodysplasia, and dual pathologies. Now, if we look here, this is data from our center, around 1,418 temporal lobe epilepsy surgeries done between 1996 and 2009. This is basically, this is the total number of resection. The temporal lobe resections were 62%. Now, what are the pathologies? This is again from the same time interval between 96 and 2009. The majority or the bulk of the pathologies were hippocampal sclerosis, but you can see around 1 out of 5 patients operated on for temporal lobe epilepsy has a diagnosis of cortical dysplasia. And the other are distributed between tumoral causes, vascular lesion, and what we call dual pathology, which is the existence of hippocampal sclerosis in the setting of another lesion. The original description for that was, for dual pathology, a lesion within the temporal lobe in addition to hippocampal sclerosis. But I think more and more we are recognizing that there are lesions outside the temporal lobe, in particular the posterior part of the hemisphere, that could be associated with hippocampal sclerosis. Now, I'm using here almost verbatim a statement from Anne Burke in Chicago, United States, where she tried to picture what is the prototypical temporal lobe epilepsy patient. So if we read this together, the average patient is in his 30s, is not anymore the case, and has failed numerous drugs. We need to fail 2 or more anti-epileptic medications to qualify, according to International League Against Epilepsy, for the diagnosis of pharmacoresistant or medically intractable epilepsy. Approximately 1/3 of these patients, they have a history of febrile seizures. It's less and less of the case now, at least in our setting in Cleveland, Ohio, in the United States. And 2/3 have MRI documented lesions. Probably, if we're lucky, around 30 to 40% of these patients, we see lesions in them. And the most common picture of the past of temporal lobe epilepsy was hippocampal sclerosis. But again, this diagnosis is decreasing by the day. Now, if we go back in time and we look at the modern series of temporal lobe surgery, and in particular, the outcome of temporal lobe epilepsy surgery, we can see here a large series coming from the Montreal Neurological Institute. And here, this is the, obviously, group of Penfield, and what they talked here, and I'm using their description. And this is in 1952, this paper was published. In 55% of the cases, the result was scored as success. There was a question about definition 1A, 1B, angle 1, 2, 3. And about half of the patients in this the success group had no attacks following operations. So probably, if you just look at this statement, around 27% of the patients operated on in the 1940s at the Montreal Neurological Institute were seizure-free. That is how my interpretation will be here, and that's basically how it will be interpreted. Now, more modern series, this is the data that was published by Pete Engel out of UCLA, and here talking about seizure-free. Okay, seizure-free between 1980s and the early 1990s. Data gathered from 100 facilities or epilepsy surgery centers. And here, out of the more than 2,336 temporal lobe epilepsy surgery, 56% of these patients were seizure-free. And then, this is before 1986. And after 1986, why the separation? This is when MRI started to be used more commonly. We see here that around 68% of these patients were seizure-free. Now, the big catch, or the big variable here that was not clear, and we'll try to clarify, is how long is the outcome? Most of the series publishing outcomes in the 1990s, they did talk about 6 months, maybe a year of seizure freedom. Consider this single point snapshot seizure-free. So I think this is good as a start, and as you will see, this may not be enough to paint a picture of what is the outcome of epilepsy surgery, and more importantly, for us try to learn from our experience to increase the long-term outcome of epilepsy surgery. Okay, so let's show you here data from our center. And this data was published maybe, 8 years ago. And what we have here is 371 patients, okay? And follow-up for at least some of them, not all of them, all the way up to 14 years after epilepsy surgery. Let's take the 10-year point. And what you'll see here, something that is very, very curious. There is a very initial, so you look at this here, very initial decline in the survival rate, which is decline in the number of patients using Kaplan-Meier curve who are seizure-free. And then this happened very early on after the surgical operation. And then this would not end, unfortunately. This continues to go down. And even 10, 14, 15 years later, we still see patients failing or exiting the seizure-free group. And that is something which would be the topic of my talk here, is try to better understand when, how, and what to do about the failures after epilepsy surgery. This is a different depiction of the same thing, showing that maybe around 60% of the patients undergoing temporal lobe epilepsy surgery, at least at our center in Cleveland, they show seizure freedom up to 10 years after surgery in this particular graph. Now, what does this data tell us? Here I'm going to use this illustration here, and to just artificially, but at least we showed, and other groups, in particular group and at the University of Western Ontario in Canada, showed that there is a cutting point, a point of the inflection between the early failure and the late failure. And what happened here, this point where I'm showing the arrow in yellow, is around 6 months, 2 to 6 months after epilepsy surgery. Most of the early failures happen. And then those patients who are still seizure-free at 6 months, some of them would continue to fail, but much slower pace. Okay, so that's why here in my talk, I'm going to separate the early failures from the late failures and try to discuss what we know about them and what to do about them. Okay. So here, if you're going to think, let's try to put hypotheses, ideas, why we may fail. Okay, we may fail because of surgical technique, incomplete resection of a lesion that was known or a lesion that was not seen. Second, we may fail, in particular in cases with hippocampal sclerosis, because the other side is sclerotic and is or becomes epileptic. Recent data from London, England, showed very clearly from autopsy reports, autopsy studies, in patients with temporal lobe epilepsies due to hippocampal sclerosis, after variable duration of the disease. Some of them were in their 20s, 30s. This is group Maria Tom, who is the neuropathologist in London. They showed that these patients, even very early on in their disease, when they looked at both hippocampi were sclerotic, showed hippocampal sclerosis, although in the majority of these cases, only one exhibited seizures at that time point. So it means the very fact that we have hippocampal sclerosis may tell us that endogenously that particular disease may be bilateral. And that is a big point that we really need to understand, especially when you're looking at late failures after temporal lobe surgery. The third cause or third reason, which could be the first one, which is the neurologist, the epileptologist's fault. It means myself. Here, we may have made a mistake in localizing where the epilepsy is. In particular, in MRI negative cases. We do the evaluation, we tell the surgeon, well, you know, this is what we have, and the surgeon will do an excellent job in resecting what they're supposed to. The patient fails. And the last cause, or last at least possible cause that I want to discuss, is a development of a new epileptogenic focus. That is, data about this is not very clear, but there are strong suggestions from selected cases and maybe small groups of patients who fail, in particular, who showed late failure in their disease. Okay, let's try to be very simple, schematic, and discuss one thing at a time. Mechanisms of early seizure recurrence. Arbitrarily, we put 6 months based on the data I just showed. These things here could be summarized, could be basically due. The most important thing is incomplete resection of an epileptic focus. And either that was recognized but could not be resected, or basically was not recognized at all here. Now, there are multiple studies here, as you can see here in the lower part of the slide, and some reference to it, that showed, at least anecdotally, that in some patients who underwent temporal lobe resections, and when they looked at their post-operative MRIs, what they showed that, oh, maybe some of these structures were not as neatly resected as Dr. David just showed us. And in particular, sometimes the dorsal part of the amygdala is still hanging there. Sometimes, and in big number of these patients, the tail of the hippocampal formation remains in place. So here, in these cases, it was assumed that these patients may have failed because the so-called epileptic substrate, that is hippocampus, was not fully resected. Okay. Now, in addition to that, and there are the studies, they talked a little bit about the entorhinal cortex. The entorhinal cortex is basically the anterior extent of the parahippocampal gyrus, and that basically is surrounding mesially the amygdala and going anterior to the temporal pole. And here basically some studies, in particular the study from Germany, it showed that 9 out of 10 patients who did not become seizure-free after selective amygdalohippocampectomy, they showed some residual entorhinal gyrus. Now, can we assume from this that this was the cause of the failure? At least this is based on this report. 7 out of 9 of these patients who had this residual entorhinal gyrus were seizure-free after reoperation. Now, these studies basically, they're suggesting that if we don't do complete resection of the epileptogenic area, we may not be very successful. Now, we can argue and discuss for a long time what is epileptogenic in mesial temporal lobe epilepsy due to hippocampal sclerosis. Is the hippocampus by itself? Is the hippocampus plus the parahippocampal gyrus? Is the hippocampus plus parahippocampal gyrus plus the temporal pole? What role does the amygdala play in this particular situation? We talk about hippocampal sclerosis, and we always resect the amygdala, either selective amygdala hippocampectomy or the more standard anterior temporal lobectomy. Why? Which one is epileptic? Which one is more epileptic? Is it the whole thing? What about the tail of the hippocampus formation? And the tail in some series is not fully resected. So now, on the flip side of this, another study showed there was no significant difference in seizure outcomes in mesial temporal lobe epilepsy patients with or without residual mesiotemporal structures following selective amygdalohippocampeectomy. So, at least looking at studies from various groups, the issue remains up for debate. How much to take, where to take. Now, personally, looking at this, studies like this, like these various studies, and the discrepant results here, will tell me that probably we're not talking about same substrate. And we're treating all epilepsies as equal. And that is what makes me more nervous. I can tell you, early on in my career, after I finished my epilepsy fellowship training, I always assumed that temporal lobe epilepsy due to hippocampal sclerosis is the easiest to treat, and it's a resolved issue from a neurosurgical and outcome standpoint. Every day I discover that I was never more wrong than this. It's not easy. It is a very complicated thing. We thought we knew where is the epileptic activity coming from. We thought we knew how to treat it, but we're discovering that we're not as successful as we thought we would be. I'm not trying to paint a very negative picture. I'm just trying to state some of the facts that we're discovering and try to all of us to think through them and to make sure whenever we are doing any surgical planning, to think about all of the possibilities before we go and plan whatever type of resection we're doing. So, what this will tell us that the issue of incomplete resection of the focus may be in part correct in some groups of patients, but it's not applicable to all patients who fail after epilepsy surgery. So what else? What do we have? Maybe it's not the issue that, oh, we know at the epileptic focus and we did not resect the epileptic focus in its entirety. Maybe it is we really did not localize it well. What does this mean? Inadequate localization of the epileptic focus actually can happen, and it does happen often. We've seen it in our center very often. A big scenario of this, what I would call pseudo-temporal lobe epilepsy. It looks, smells, acts like temporal lobe epilepsy, but it is not. Can it happen? Unfortunately, it does. Are there any, what we call, red flags? Something to tell us, be careful. Maybe it's not mesial temporal lobe epilepsy. Maybe it's not temporal lobe epilepsy. And the answer to that is yes. And that is the role of the epileptologist. And you'll see why. That is the role. Some of us asked questions early about video-EEG monitoring. Do we need it? Of course we do. And I'll be happy to discuss. Why? Because you're going to see that semiology is of the essence. Correlation with EEG is extremely important. Now, this is a paper from the group in Grenoble, France. And basically talking about what they called temporal plus epilepsy. Temporal plus epilepsy is basically a term to describe what we call at Clevelend Clinic temporal perisylvian epilepsy. So it means we extended the concept of the epileptogenic area from outside the hippocampal formation to the whole temporal lobe, to the opercular area, to the insula, anterior and posterior. When we open this up, you're going to see that the issue is not that easy to resolve unless we think through this. In this particular paper, what basically they divided their patients, 58 of them, into what they called pure temporal lobe epilepsy. And then they had 22 patients, what they called temporal plus. Means temporal, but something else. And then they said that it was difficult to differentiate between these two groups based on the MRI data. Obviously, they are MRI negative. And then in some clinical features, basically the ictal clinical symptoms and the scalp EEG did not significantly differ between the two groups. So, but what was different? What was different here in patients with temporal lobe epilepsy proper, they had more abdominal aura, more automotor, gestural automatisms, fidgeting, movement, lip smacking. And then these patients, they had more prevalence of what we call post-ictal amnesia. Okay. Now the temporal plus patients, not a surprise, they had more gustatory auras, taste aura. They had more vertigo, dizziness. We're moving outside the mesotemporal lobe, obviously. We're going to have these type of things. They had auditory auras, facial gyrus, temporal opercular area. They exhibited more frequently contraversive, or what we call versive movement. And I know Dimitri is going to be giving us all of the characteristics of various movement of the head. But the versive movements, they're more exhibited in patients having epilepsy from outside the mesial structures. They exhibited more tonic movements because they are very close, or closer. If you are lateral temporal, closer to the primary motor area. Makes sense. Okay? And they had some more emotional changes, dysphoria in the post-ictal state. The authors here basically observed that neither temporal lobe interictal spikes nor temporal lobe ictal EEG in these particular patients allowed them to definitely rule out possibility of temporal plus epilepsy. And they concluded that the findings may be useful for the identification amongst patients suffering from atypical, non-lesional temporal lobe epilepsies, those who should undergo invasive evaluation. In this particular situation, I think stereo EEG would be a better answer because of the complexity, three-dimensional complexity of the structures that could be potentially involved. I mean by that, you're talking about opercular areas. You're talking about anterior and posterior insula. These are structures very difficult to cover with subdural grids, for example. Okay, so why are we at risk of making diagnosis of pseudotemporal epilepsy, the wrong one? And how can these simulacral differences be explained? So, I'm going to try to make a case for something that seems to be very complex. I'm going to try to simplify it just to illustrate a point and leave the rest for your imaginations. Okay. This is a very complicated diagram. I'm not a mathematician. I am just a simple neurologist. Not as smart as the surgeons. I'm just a beginner in the field. So here is what we have. So what I'm showing here in red, and this is study from our group, mapping, stimulating each one of these areas and recording from whatever we can record from the brain. It was published. So, posterior hippocampus, anterior hippocampus. I'm showing two different groups of arrows. I'm showing the light gray arrows here, showing you the connection going outside the hippocampal formations. And look at this. So just study the whole anatomy of the brain actually in one single slide. What you see here, you see posterior singular gyrus, precuneus, intraparietal, inferior parietal lobule, lateral temporal lobe, temporal pole, insula, anterior singular gyrus, medial prefrontal, medial orbitofrontal, amygdala, parahippocampal gyrus, going outside to the pre-SMA, lateral orbitofrontal, going to the lateral occipital, to the cuneus, looking contralateral to the other side, looking to the posterior cingulate, precuneus, cuneus, posterior hippocampus. What does this mean? It means here it could start in one hippocampus and look everywhere. That's not what I'm talking about. What I'm talking about is the reverse. What about here, the connections from outside the hippocampus to the hippocampus? And this is in red. You're going to see in red here, the hippocampus could be activated, and it could look like it's hippocampal epilepsy if the precuneus or posterior cingulate is epileptic, or if the temporal pole is epileptic, amongst multiple other things. If the amygdala, if the parahippocampal gyrus. So this is just, I'm showing you this as a proof of concept, at least hypothetically, that we can have a patient showing seizures, have an EEG, looking and smelling like it is hippocampal epilepsy, and it's not. It's a spread from a network of structures connected to that hippocampus without being hippocampal epilepsy. Now, if we record and we just say it looks temporal lobe, oh, we have automotor seizures, we have whatever, we have an EEG there, the surgeon will do a phenomenal job. It could be selective or anterior temporal lobe epilepsy, and this patient is not going to be seizure-free. And these are typically the patients who fail very early on after surgery. So, these particular situations, we really have to be very, very, very careful. So, now, what I want to show you here is some illustration of this point. And what I'm using here, I'm going to use a patient of ours. This is a patient who was suspected to have temporal lobe epilepsy. But this patient was MRI negative. Now, in this situation, and in our protocol now since 2009 at Clevelend Clinic, we implant various structures of the limbic system. So you can see here the various points of this implantation. We have orbitofrontal, we have middle frontal gyrus going to the anterior cingulate. We have the temporal pole, essential. Looking at the temporal pole in these patients, it is very, very important because it's a big hub, big station that gets to the hippocampus and goes outside. Amygdala is equally as important, anterior hippocampus, posterior hippocampus, basal temporal anterior. F here, this is the fusiform gyrus. The fusiform gyrus is one of the longest anterior posterior gyri, going from the temporal pole to the occipital pole, just in the middle. And that gyrus, in particular, at the junction between occipital and temporal, it is a big hub, big station for information coming from the precuneus, from the parietal lobe, down to go to the hippocampal formation. So that particular area is very important to sample in cases where MRI is negative and we're suspecting some type of temporal lobe epilepsy, or if you may call it limbic epilepsy. Now, the fusiform gyrus, from that station, there is direct connection to the parahippocampal gyrus, from parahippocampal gyrus going into the hippocampal formation. So an epilepsy from there, although it may have some different semiology, but it may exhibit itself in a pseudo-temporal fashion. So anyway, what did we find in this particular patient? What we find actually is very interesting here, that the EEG onset in this particular patient here, it does start in the, let's try to forward, in the posterior cingulate area, in that electrode. And this is where it is here. And then you see here, very fast, this activity goes to the anterior, to the posterior, then anterior hippocampal formation, before it did spread and it did act as if it were to be very nice hippocampal epilepsy. So if we had resected the hippocampus here, I don't think we would have been successful. I think Alessa, she's with us in Cleveland now, and she's studying. We have, what, up to 150 patients with hippocampal electrodes, and she's finding exactly this. If the activity starts somewhere else, although it ends in the hippocampus at whatever stage, the hippocampus doesn't need necessarily to be taken out, correct? So this is an illustration of what is the benefit here of thinking about these cases and at least think about possibility of pseudotemporal epilepsy. Now, this is a little bit more complex, but this is to illustrate the point I just made, that it is probably connection that's given us the impression of hippocampal epilepsy, but it is not. So here, and this is my colleague Dilip Nair with one of our fellows, Ray Inatsu, who's now back in Japan. What basically they did, they stimulated one electrode and recorded from the rest. This is what we call cortical evoked potential. Just simple evoked potential. And what they showed here documented the connection between the posterior cingulate, precuneus, and the mesial temporal electrodes. Just as a proof of concept that what we are seeing on the EEG is following the physiological connection, that they do exist as part of the limbic system. And that's basically how they do. Now, do we have more cases? I'm going to show you another case here that basically made us pause a little bit, but the MRI saved us. And I'm going to ask you after I finish to think, what if the MRI was negative? Now, look at this here, 27-year-old right-handed patient whose seizures started back when he was 19, not very early. And seizures, butterflies in the stomach. We may all call this some type of abdominal odor, wouldn't we? And then nausea. Then he had dizziness. Temporal plus, what we read is, may not be part of the mesial temporal lobe epilepsy per se. Tingling in all fingers. We had a case yesterday, we had a small discussion. Cases probably it's secondary somatosensory area. Could be involved primarily or could be a spread to that area. Followed by blank stare and absence. Prominent hand automatisms, usually picking his clothes. Okay? And at times leading to secondary generalized tonic-clonic convulsion, very frequent seizures, failed multiple anti-epileptic medication. Here is the problem. Semiology may not be a problem, may not be. We have red flags. But interictal sharp waves, they were left and right temporal. Anterior temporal, we usually put sphenoidal electrodes during our scalp EEG evaluation, and they were left and right sphenoidal. Ictal, some seizures were left, some seizures were right, anterior temporal. It's a problem. So now, what if the MRI is normal? Most of us will not do anything, and probably it will not be a bad decision. And if we're going to do something, guess what? You have to implant bilaterally the same way you implanted that patient we just showed you earlier, isn't it? You have to assume could be left, could be right, could be left to right. Here you want to rule out independent left and right, but the MRI did not, if it doesn't show any hippocampal abnormalities, we are in trouble. Now, we were not in this particular case because I think, as you all will see, there is a beautiful something here, dark, on flare. I'm talking like a neurologist, am I not? So basically an area of significant decreased signal on flare and on T1. And it is in the posterior part of the precuneus. So big debate we had. This is a long time ago, maybe 10 years ago we had this patient. And then we thought, well, you know, we have this lesion, what should we do? The epileptologist wanted to implant this patient. The neurosurgeon, Bill Bingaman, he said, no, I'm taking it. I'm not gonna keep it, I'm taking it. And he did. And the patient became seizure-free. Now, how can we explain this? If we go back to a beautiful book by Henri Duvernois, The Hippocampus, I strongly recommend this book for those of you interested in a career in epilepsy and epilepsy surgery. A beautiful illustration of the anatomy, histology, connections of the hippocampal formation. And what he showed here basically very simple. Showed precuneus to cuneus, cuneus to the parahippocampal gyrus or the lingula parahippocampal gyrus to hippocampal formation. So it can look like it is hippocampal epilepsy. And then you can see here it goes from one station to another, and it may end up here. There is more data actually, and this is data from rest in state functional MRI studies. This is a study published in 2009 in the Proceedings of the National Academy of Science in the United States. And basically what they showed, very simple, that the ventral part of the precuneus, it does basically send connections toward the mesial structure of the temporal lobe, in addition to sending connections to other areas of the brain. Okay, so what I showed so far here are two possibilities why we may fail very early on. We may fail because we did not resect the epileptic structure completely. We may fail because we did fail to recognize an epileptic focus outside the hippocampus. Okay. Now here, what could be predictors? What things we can use, or we can, from history and from previous evaluation, we can say, well, this patient is more likely to fail early on if a patient has a history of generalized tonic-clonic seizure. The magic number, it seems like, I don't know why. History of 20 or more grand mal seizures. The second possibility, bilateral MRI abnormalities. Of course, if we see in hippocampi not looking well early, both sides may fail. And there is something very interesting, because one of you, I think, asked an essay here, what do you do, these patients, when do you stop anti-epileptic medications after surgery? We have an easy, at least early screening, which is basically post-operative EEG at 6 months. It's very, very predictive. Very predictive of, or if the EEG doesn't show spikes at 6 months, it is less likely that this patient is going to fail later on, assuming they have not failed so far. If they have spikes, there is a higher risk of failure, and at least in our hands at Cleveland Clinic, we do not stop anti-epileptic medications if we see spikes at 6 months after epilepsy surgery. Just simple. And especially if they have, you know, a bilateral MRI abnormalities, they have big history of grand mal seizures, you may want to hold on pushing anti-epileptic medications down. And by the way, when we talk to the patient about epilepsy surgery, we talk about one single thing. We are doing epilepsy surgery not necessarily to stop anti-epileptic medications. We do epilepsy surgery to transform a pharmacoresistant epilepsy into a pharmacoresponsive epilepsy. It's a very important point that I think we have to understand. Now, as an additional benefit, some of these patients, we may get lucky and stop one medication, 2 medications, and a smaller number of these patients, we may stop all medications. I'm a little bit more prone to stop medications in a woman of childbearing age who is want to become pregnant, which is, I think, very understandable type of behavior to stop the medications in these particular situations. Those patients who underwent invasive evaluation, at least in our hands, they tend to fail more. Why? Because if they were not complicated, we would not have put electrodes in. And therefore, probably, we have some deficiencies in our mapping. So here, basically, to reiterate, these are the two possibilities for early failure. not a good localization, not a complete resection. Now what about these late failures? You can see here this slope continues to go down, albeit is slower pace. And at 10 years, and this is data from an invasive series that Juan Gulacio from our group published, it basically goes from around 60% seizure-free at 1 year or 70% at 6 months to around 35% of them seizure-free at 10 years. So there is some decline. So half of the failures happen within the first 6 months, the other half continue to happen for 10, 15 years. So, what are the mechanisms of late failure? In these situations, we do not think the issue is about completeness of the resection or not. We think that in these patients, the recurrence of seizures is independent of the completeness of a resection. The resection was complete of the identified epileptic focus. But most probably here there is a new variable. The new variable here is incomplete or no resection at all of what we're going to call a pro-epileptic focus. What we mean by that, it is a part of the brain that has all what it takes to be epileptic, but was not at the time of the surgery. And I'll show you some data here. So, the pro-epileptic focus in temporal lobe epilepsy, or temporal lobe epilepsy surgery, could be the contralateral hippocampus. We just talked about it. We have from autopsy studies as recent as 2010, as early as 1964, showing, autopsy studies showing hippocampal cirrhosis is unfortunately a bilateral pathological finding in almost every case that was studied. So you could assume you take one sclerotic epileptic hippocampus and the other one may become epileptic in 1 year, 2 years, 5 years, 10 years, 15 years, may not become epileptic immediately after, unless it was bilateral independent epilepsy to start with. And the second part would be development of what we're going to call epileptogenesis from a contiguous tissue to the tissue that was resected. Okay. Now, bilateral hippocampal sclerosis, basically it is something that we see and that it does happen in a good number of our patients. Show you a case here. This is a patient of mine, 28 years old, and he had his first seizure at the age of 10 in the setting of encephalitis. Already is complicated. Seizure semiology looks and smells like a temporal lobe, mesotemporal lobe epilepsy. EEG, video EEG evaluation showed the majority of the spikes interictally are in the right temporal, 95% to be precise, and only 5% of them coming from the left side. Seizure semiology, automotor seizure, and the EEG, ictal EEG, was right temporal. So we looked at the MRI. The MRI was more abnormal on the right than it is on the left. And this is a situation where we said, well, you know, probably he may benefit from a resection of the right temporal lobe, which we performed in 2001. Now, what happened here? The patient became seizure-free. The pathology was hippocampal sclerosis. He remained seizure-free for almost 6 years. And then seizures recurred. Almost same semiology, while he was still on anti-epileptic medication. Repeat evaluation showed no interictal sharp waves, but seizure semiology basically is the same almost, and pointing to the right hemisphere, the same side where the surgery was done. And then the EEG basically is right-sided, either right temporal or right hemispheric. So we thought, probably in this particular case, we need to extend the resection, we need to take more. And that is basically what was the resection, the initial resection of this patient. So the hippocampal formation is almost completely resected, as you can see here. It is an anterior temporal lobe resection with removal of what we call mesial structures. So what we did here, we put depth electrodes. These are one of the earlier cases of our SEEG implantation. Jorge Gonzalez, our second neurosurgeon at Clevelend Clinic, performed this operation. What he put basically, he sampled the insula, sampled the orbitofrontal area, whatever is left of the limbic system minus the precuneus. This is in the site of the resection. And we put one lonely electrode in the other hippocampus. Why? 5% of the spikes were left in 2001. Hippocampus did not look well. Said, oh, let's put an electrode, like an excuse me style implantation. Now, what did we find? 100% of the interictal spikes were coming from the left hippocampus. We recorded no spikes after surgery from the left. 0. Now, what about seizures? Seizures, basically, all of them started from the left hippocampus. But we recorded everything on scalp from the right, correct? How does it happen? Look how it happened. Within 35 seconds, the seizures moved to the right to the right opercular area and insula. Very fast, 35 seconds. And then, after that, they took over the lateral temporal lobe, or what's left of it. This is an unfortunate case of mislateralization because of connections between these various areas that we did not recognize. This is the other hippocampus failing or becoming epileptic almost 6 years after the first one was taken out, being the cause of the recurrent seizures, with a video EEG and all of the evaluation continuing to mislateralize that particular case to the other side. Now, this will raise the issue of what we may call bilateral hippocampal sclerosis. And this is a case from England, basically. 5 of 20 patients with hippocampal sclerosis who had seizure recurrence showed evidence of contralateral temporal lobe seizure recurrence. So at least a good percentage of patients who fail, in particular late failures, they fail in the case of temporal lobe epilepsy because of dormant contralateral hippocampal sclerosis. But the other side of this, it's not the only reason for this. And as I mentioned, a possible other reason is a pro-epileptic focus that developed into an epileptic focus after a successful initial epilepsy surgery. And then here we can, and we have some data here that we published on this particular topic, some data suggesting that the pathology is there, not hippocampal cirrhosis, we're talking about cortical pathology. May be there, but may not be active at the time of the resection. Part of it may be active, we take it out. The other one is not active, will become active a little bit later on. Another case here, 53-year-old male, automotor seizures, abdominal aura since early on in his childhood, failed multiple anti-epileptic medications. Evaluation showed early in 1991, temporal lobe epilepsy from the left. Anterior temporal lobectomy was done in 1992. Pathology was hippocampal sclerosis. Seizure-free on and later on off AEDs, anti-epileptic drugs, for 13 years, from 1992 to 2005. In 2005, he slid on ice. Cleveland is a little bit more cold than here, and it snows quite a bit. He slid on ice, hit his head. Seen in the ED, emergency department, they didn't find any bleed, nothing. Sent him home, and after that, his co-workers, who used to work with him before he had his surgery, they started to describe and to see that this patient has just staring spells with some weird movements. Upon questioning, said, oh, I feel I have an aura of my fingers tingling. So anyway, so we readmitted him after he failed medication and showed left temporal epilepsy. And looking at the MRI, we saw that the small part, the amygdala and small part of the posterior hippocampus remain in place. What we did here, this is before SEEG. What we did on him, we put a mixture or a hybrid invasive evaluation of subdural grids covering the lateral temporal, perisylvian area, and the above or the dorsal part of it, frontoparietal dorsal part of it, covering the basal temporal, and put a couple depth electrodes in the amygdala and the posterior hippocampal formation. What basically we found in this particular case, that the seizures are coming from mainly the posterior end of the resection, the stump of the resection here. Now, what we did here, we could not be very aggressive because speech areas were here. We extended the resection inferiorly in the middle temporal gyrus, inferior temporal gyrus, and stopped there. The pathology was corticodysplasia type 2A, which means architectural disorganization with dysmorphic dysplastic cells. Now, we don't know of any data or study showing postnatal, late postnatal development of type 2A dysplasia. This will lead us to assume that this type 2A dysplasia was there probably since birth, if not before, and it became epileptic 13 years after the successful epilepsy surgery. You ask why? Say, I don't know. I know one thing. If I take patients with corticodysplasia, and all of them who were operated on, and put in a plot, when was their first seizure? The majority of them will have their seizures first 10 years of life. But I have some of them will have the age of 20, 30, 40, 50, even 60 years old patients, they had their first seizure from corticodysplasia. Why not here? So this is to illustrate that the late recurrence here may, in some of these patients may be a pathology that was not yet epileptic but became epileptic, like any new pathology that becomes epileptic. Now, some findings here, if you look at the data coming from about outcome in patients with focal corticodysplasia, they will tell you the best outcome is balloon cell dysplasia, type 2B, followed by type 2A, followed by type 1. Type 1 focal corticodysplasia is the worst, and probably because it's more widespread. You take an epileptic focus, the next area will become epileptic in 2 years. The third area will become epileptic, and like they say in English, you'll be chasing your tail. Cut, 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 in the end, nothing else to cut. So this will lead me to conclude at least this part of the talk, and talking about these to summarize what I wanted to convey to you. In temporal lobe epilepsy, there are two types of failures, at least from a temporal standpoint. Number one, the early failures that are likely due to some remnants of the mesial structures being in place, or the fact that the localization was not correct from the beginning. An example here, pseudotemporal lobe epilepsy. Look outside the hippocampus, maybe outside the temporal lobe, but within the limbic system, especially in MRI negative epilepsy. Late failures, either the other hippocampus was sclerotic but was not active at that time, will become epileptic later on, or a contiguous tissue that in this situation, most of the, at least data, points to a possible cortical dysplasia here. Now, I will end my talk here with sharing with you some information about what to do with these patients who fail. What is the outcome? What do we know about them? And we have some small series here of what, can we reoperate on them? And if we do so, what does or do these reoperations tell us? This is basically data from Germany, review of 15 case series, 402 patients, describe an overall chance of seizure freedom in these patients after a second resective surgery, around 36%. 36% of patients who fail will become seizure-free after the second surgery. Very high complication rate, because these are the cases where you're going to have a lot of adhesions, you're going to re-implant them, more bleed, and one of the reasons here may be we're getting closer to eloquent areas, and therefore a patient may have some post-operative deficits. This is a data from our center. Very complicated, at least to start, but just to tell you, looking at 68 patients who had seizure recurrence after temporal lobe epilepsy surgery, and then looking at the focus of recurrence. Was it identified or not? In 44 out of 68, we thought that we know where the focus is coming from, or at least we did an evaluation to identify this. And in those patients here, the recurrence hemisphere, just what do we say, ipsilateral in 29 out of 44, the other side in 7 patients, and bilateral in 8 patients. So the majority of the recurrence, at least from our series, were ipsilateral. Now, where from? Now, what we're seeing here, if we talk about the ipsilateral here, 3 patients from parietal lobe, probably pseudotemporal here, 8 patients mesial, 2 basal fusiform gyrus area, 10 posterior. Posterior lateral temporal, posterior fusiform gyrus, and 6 patients frontal. So frontal mislocalization, parietal mislocalization, so we have 9 out of the 29 patients. Now, reoperated on, none of the 3 patients with parietal lobe we did reoperate on, could be variable reasons. Most of the time it's speech and functional issues. 6 of the 8 patients with suspected mesial temporal recurrence were operated on, 2 of the basal temporal, 3 of the posterior temporal, and 4 of the frontal lobe patients. Seizure free, 0 frontal lobe, 0 posterior, 2 basal, and 4 mesial. So the point here to say that these are telling us that contiguous areas of the resection, when they're involved, we may be able to be successful, not in all cases, but if they are outside, probably we're still missing the thing. We need to have more global evaluation. This data was generated before SEEG electrodes were available. So what to do if the temporal lobe epilepsy surgery failed? First things first, very important here in these particular patients, establish resistance. Because one thing we described actually, a late failure after epilepsy surgery would act like it's a new onset epilepsy. So it means there is a good chance, maybe 50 to 60% of these patients may become pharmaco-responsive, okay, after they fail. So don't give up, don't assume immediately that these patients are going to become pharmaco-resistant. And second, find out what type of spells they have. Because we've seen this. We have many patients who fail late and they end up having non-epileptic seizures. It's a very common thing, and that is the value in these cases of very careful video EEG monitoring. Now, if we decide to move and the patient is pharmacoresistant, we really think that the best way, in case of what we may call temporal perisylvian epilepsy, to perform an invasive evaluation, to cover the limbic structures according to a very detailed map that I will share with you. And don't forget the other side. So this is basically a small illustration of, we know about the ipsilateral area of coverage, and I'm showing you here a more detailed one. Our neurosurgeons will get very scared when I show them this type of map, because in particular, Jorge Gonzalez will ask me, 15, I stop. 15 electrodes and I stop. So he starts counting, he doesn't look where. And when he goes beyond 15, he starts looking and said, well, remove some of them. But the point here is to talk about the structures that could be activated part of the limbic system. Don't forget the other side. Now, what is unresolved in these cases is where on the other side, when on the other side, and how many. Okay? So I will end my talk here. I hope I did not confuse you too much. But more important here, the big message I wanted to convey is the fact that temporal lobe epilepsy surgery is successful. And when it is not successful, let's go in a systematic manner and go through these possibilities. Because in the majority of cases, even after the failure, we are successful, either by using medications or optimizing the surgical procedure or the diagnostic localization procedures followed by another surgical evaluation. Again, thank you very much for the opportunity. I do appreciate your
Dr. Najm, thank you very much for the excellent